Welcome to the PETAL Podcast. PETAL Consortium is a global network of more than 100 investigators from over 20 international research sites dedicated to advancing care for peripheral T-cell lymphoma, or PTCL. In this series, we will explore topics related to PTCL to help guide healthcare professionals when caring for patients with this rare and aggressive blood cancer. Hi everyone, I'm your host, Dr. Julia Zhang. I'm a T-cell lymphoma doctor at Moffitt Cancer Center in Florida. In today's episode, we'll be discussing frontline treatment in nodal PTCL. Joining us today are Dr. Stefan Barta, the Director of T-cell lymphoma program at University of Pennsylvania from United States, and Dr. Estelle Verburgh, a clinical hematologist and Director of Stem Cell Transplantation at University of Cape Town in South Africa. Welcome. So Stefan, the first question. So imagine with me, there sits a patient with newly diagnosed nodal PTCL in an oncology clinic very, very far away from Pennsylvania, okay? He's very symptomatic. He wants treatment soon. So we know there are several frontline treatments for PTCL. What are the first factors you look at when you're choosing between CHOP, CHOEP, BVCHP, clinical trial, or referral to a lymphoma specialist?
Yeah, thank you, Julia, for inviting us today to this exciting podcast. Happy to join. There's always a lot of factors when you see a patient, a lot of things that go through my mind. And first of all, I'd like to make sure that we really have established the correct diagnosis. Oftentimes, there's a lot of time that elapses between a biopsy and the diagnosis being made by a hematopathologist because it can be sometimes very tricky. So I'd like to look at the path report and make sure that it's looked at by a hematopathologist who has some expertise in T-cell lymphoma. And we want to make sure that all the important tests have been done, that we need to confidently establish a diagnosis, the appropriate immunohistochemical stains, that includes CD30 expression, for example, but also in some circumstances, molecular markers or other genetic testing, such as T-cell receptor rearrangement. And once we're fine with making sure that the diagnosis is correct, then of course staging is the next important part. So we want to make sure that we have the appropriate staging exams performed, ideally a PET scan if available, because a lot of the T-cell lymphomas have extra nodal involvement, and the CAT scan sometimes does not pick that up. And the bone marrow biopsy, if possible, as well, because bone marrow involvement can sometimes be not apparent even on a PET scan in about 10 to 20% of the patients. And next, the laboratory results. So that includes, of course, the routine blood counts. And that will be important in terms of what therapy we're choosing, depending on whether there are already low blood counts present, or cytopenias present, for example. We look at kidney and liver function as well. We look at the LDH, lactate dehydrogenase, to tell us a little bit about tumor bulk and the risk of, for example, tumor lysis. And then also some other tests, special tests, for example, viral serologies for hepatitis B, hepatitis C, HIV, and that is just important to know about. It doesn't really change necessarily the cancer treatment, but it changes the supportive care treatment that we need to be aware of that. And also HTLV1 for many of our patients, it's something that often is overlooked and sometimes can a diagnosis of, for example, ATL can be missed. And then once I have the right diagnosis and the proper staging, then of course the next thing is the patient and their comorbidities. Is there, for example, are there, for example, cardiac comorbidities? Is there renal impairment, liver impairment? Are there other disorders like autoimmune disorders? So these things are important to really tailor a regimen to the patient, and medications as well, because there can be drug-drug interactions between medications. There's a lot of things that go through our mind, so it's not just a very basic yes or no, you need treatment, but we really have to have all that information to be able to tailor the treatment to our patients. And then it usually, as you said, the decision is between clinical trials or standard of care. And as we know, we always want to improve the outcomes for our patients with T-cell lymphoma. And many of the guidelines recommend a clinical trial as the first treatment, but it can be at times that the patient, as you had mentioned, has a lot of symptoms, and there may not be time to do all these necessary workups to determine eligibility for a clinical trial. And treatment in the community may be the best first step for some patients if they can't even make it to the specialist. But in general, also, it's not a bad idea to get a second opinion prior to initiating therapy, just to make sure that everybody's in agreement what the best treatment be, whether that's CHOP or CHOEP, which is mainly for younger patients, or infusional EPOC or BV-CHIP.
Thank you so much, Stefan. That's a great overview. So I'm curious now, Estelle, I know you're in South Africa. How's the practice over there?
Thank you for the kind introduction, Julia. I think Stefan has set the scene very, very well, and I can absolutely find my own practice in what he said. That is exactly what we will be doing. PTCL may be a difficult disease to treat well, but it's actually very standard what we have to do, and we have access to all these things. The one test we don't have such ready access to, and I will tell you why, is a PET-CT. And I think, that is the one thing I can miss. I'd rather have good treatment. So as you allude to, I am actually speaking from Cape Town, South Africa, and I work in the historic Academic Hematology Center, where the first bone marrow transplant on African soil was performed in 1974. So as an academic clinician, I care for the fully 85% of South Africans who are dependent on state-funded care. In other words, the uninsured patient. So for that reason, the resources are somewhat constrained. So the frontline therapy for PTCL in our center is still CHOP or CHOEP. And beyond the access we do have to transplantation intensification in my center, we have scant access to novel treatments.
Thank you, Estelle. So the second question for you is that you mentioned a little bit the treatment options are limited. We know that BVCHP has changed the frontline conversation in the CD30 expressing PTCL in the US. In what patient is this your preferred frontline regimen, assuming that you have all the resources, and hopefully you will have all the resources? And also, when do you pause before using it?
So that's an excellent question, Julia. And from my side, unfortunately, I must put a rather big pause in answering your question. So in my context, BVCHP has only been registered for use in frontline PTCL treatment since a few months ago, earlier this year in South Africa. So now that will be available to the 15 to 20% of people who are insured, and it will not be available to the uninsured patients in my center. So in state-funded care for uninsured patient, this type of drug would be available only very sporadically through a special circumstance or program. And the use in my center has, for example, been in young patients with advanced stage ALK-negative anaplastic large cell lymphoma, where it worked very well, but not in other PTCL. So in addition to the clinical data we are collecting on our PTCL patients, we have a great focus in our research on improving access. And for that reason, we study health economics data to increase access to focus and aim to increase access to novel treatments such as BV chip, because in that way we can work to prove cost effectiveness. Now, cost effectiveness is difficult to prove in a low resource country, but at least you can work towards a cost neutrality analysis. And with the cost that actually goes into treating a patient, if you would use novel treatments, you can actually reduce the cost of treatment and you can increase the outcome, a good outcome. So, and then you can compare this using a novel combination to currently used chemotherapy treatments such as CHOP or CHOEP.
Thank you, Estelle. Yeah, I can hear from, your voice, there's definitely a lot of struggle, but I'm very glad you're doing all those cost analysis and hopefully that'll help bring in your agents. So Stefan, for you, I assume you don't have trouble obtaining BV. Any thoughts to add for patients in the US?
So I do echo Estelle's conception that I think the largest benefit of adding brentuximab to CHOP or replacing the vincristine in CHOP and this then makes BV chip is for patients with anaplastic large cell lymphoma. When we look at the data from Echelon 2, these are really the subgroup of patients who benefited the most. And for the other subtypes, such as, for example, PTCL not otherwise specified, or the T follicular helper T cell lymphomas, including the angioimmunoblastic type, it's less clear that brentuximab really adds a lot of benefit, although this always has to be also taken into context of the whole study that included everybody with at least 10% CD30 expression in the Echelon trial. It is currently approved for patients with 1% or higher expression in the United States as a frontline regimen. And that's the other issue is truly the strength of CD30 expression in the non-ALCL T-cell lymphomas. Is that a good biomarker on which to determine whether to give brentuximab or not? And I'm not sure there again about the data. The data is very conflicting. So it's so I do think that if there's a clinical trial available for patients in the non-systemic ALCL group who do have CD30 expression, I think, and there's a randomization to CHOP, I think that would be absolutely a fair point. I think CHOP or CHOEP is probably just as good as BV chip for these patients. However, I do discuss this with patients, and specifically for high risk or younger patients, I do consider BV chip for any CD30 expression, even if they're non-ALCL subtype, because it did not appear to be the worse, and the toxicity was about the same. But clearly, it's also a cost issue that we have to take into account, and as a society, have to take responsibility for all of our patients.
Thank you so much, Stefan. Yeah, that's the struggle of our life. There is no subtype specific studies due to how rare the cancer is. So Stefan, next question is hard. So we know that PTCL is not one disease, okay? And when the pathology report comes back, and we know it's a lot of words, a lot of sentences in there. My question is, what words or markers should make a community oncologist stop, rethink the plan, or call a lymphoma specialist?
Yeah, this is really a difficult problems that we sometimes struggle with, even for someone who is seeing a lot of T-cell lymphomas. And as I had mentioned, there's often delays between the diagnostics specimen collection and the diagnosis, because the sample gets sometimes sent to expert pathologists to have a look, because it's not that easy to distinguish these abnormal T-cells from the normal T-cells and what is a reactive process. And then further, as you mentioned, the subtyping. And thankfully, we sometimes have a lot of other means, such as mutational testing, that can help with a diagnosis, but that takes a little longer. There's actually been a study that was published a little while ago looking at big tertiary centers in the United States and their referral patterns and their hematopathology review. And in about a third of the cases, 25 to 30% of the patients who were in the community diagnosed with peripheral T-cell lymphoma, the diagnosis was actually modified to a degree, either different subtype or actually a different disease, such as, for example, Hodgkin lymphoma. And vice versa, Hodgkin lymphoma can sometimes be an anaplastic large cell lymphoma. Sometimes can be misclassified, for example. So what are markers that should make you, or words that should make you think twice? Well, number one is if there's no clear diagnosis and there is favor, but could also be that these are words where you might want to have a second look. And then certain things, for example, if things are not fitting the picture, if there's not 100% CD30 positive, but the positivity, but the diagnosis is a anaplastic large cell lymphoma, or if you have an extranodal NKT cell lymphoma, but the EBV staining is negative. So things that don't fit, or I've had several patients who were diagnosed, for example, with T-cell PLL, but actually had Sézary disease, and the TCL1 was not checked, or other things. So I think just being thorough, checking off all the marks, and if there is any ambiguity, don't be afraid to ask. And as I said, second opinions are very important and very helpful, and we all benefit from having another person who has expertise glance on it. And I'm always trying to make also my community colleagues aware that we're there to help, and we have resources that may not be available to the community, such as, for example, the molecular testing or the mutational testing that can sometimes be very helpful to, for example, establish a diagnosis of the T follicular helper T-cell lymphoma, which goes with certain very specific mutations. So I'll always offer them my phone number, and they know how to get a hold of me to discuss and help them out.
Perfect. Thank you, Stefan. I didn't know. So 1 in 3 patients diagnosed is modified after expert hematopathologist review. That's I think everybody should at least get a hematopathologist review for the slides. So Estelle, how does the diagnostic pathway look like in South Africa?
Yeah, Julia, I am happy to report that we have an excellent hematopathologist, lymphoma specialist, anatomical pathologist in our center. I think it is both science and art, and to have access to a single person who always looks over your diagnoses, even though it's a bigger group, that is extremely valuable. So interestingly, in South Africa, I can actually report that both the insured patients and the state-funded patients will have access to good and uniform pathology reporting for the diagnosis of PTCL. So the diagnosis is seldom in question. Is it always accurate? I agree with Stefan. It's not a given in lymphoma diagnosis. That's also why you need a proper specimen. But we've actually worked with a well-known United States cancer lab in validating our diagnoses. It's still in process, and actually it's been well validated up to now. I'm not saying it's perfect, but I can trust our diagnoses. So one reason for this could be that the pathology specimens for state-funded patients are all sent within the one lab network, the countrywide National Health Laboratory System. And there is a certain standard throughout the country. So what is not what I would wish for my patients, what is not so positive and advantageous for patients, is that the diagnostic referral pathways, and Stefan has also referred to that, that they are not what you would wish for your patients. They are torturous. Biopsies is not often accessible in many layers of the healthcare, and that results in many late diagnoses with patients presenting at an advanced stage. So in my region, as everybody probably knows, in South Africa, a lymphoma diagnosis can be obscured and delayed by the presumption of HIV and TB. So we are HIV and TB experts, global, but we are not always that expert in the pathway of lymphoma diagnosis. So that's the reason our research and our clinical focus in Cape Town is really focused towards improved access to biopsies, learning around what type of biopsy is a proper biopsy, training of other clinicians in point-of-care biopsies or ultrasound, and lymphoma diagnostic pathway education that has to extend to primary, secondary level healthcare workers. And this is all aimed towards treating PTCL early and accurately.
Oh, that's so well said, treating PTCL early and accurately. Thank you, Estelle. So final question here. So in frontline nodal PTCL treatment, what is settled, what is still debated, and what is one thing that community oncology team should remember after this episode?
I may not speak for America, but I think it even happens there. It's that even the surgeons doing the biopsies, when I started this whole initiative towards early diagnosis, and we worked with them, because you always work, you do that Chinese art of joining what you're perceiving as the enemy, and they are our best co-workers and our champions. But they, at that stage, 10 years ago, said, the one consultant said to me, but why would you want to diagnose lymphoma? You don't treat it. So that's the message I have. So in this case, we're speaking of PTCL, peripheral T-cell lymphoma. Even though it's not so common as the B-cell lymphomas, it's a prevalent cancer and it can be cured. So failures in a diagnostic pathway can lead to misdiagnoses or late referrals for treatment with resulting poor outcomes. This is what I want them to understand. It's not a fatal diagnosis. It should be diagnosed timeously, accurately. And that is why colleagues like Stefan at UPenn and in Cape Town, my colleagues and I, are focused on increasing PTCL awareness and treatment access among not only patients, but among colleagues also.
Thank you, Estelle. So increasing awareness, confirm the diagnosis through an expert eye, know your patient, and most importantly, don't hesitate to pick up the phone to call your T-cell lymphoma expert. Okay, so Stefan, what about anything to add here? What excites you for the next decade of treating PTCL?
Yeah, so I think this was all very well said, and I think it is very important to change the preconception of T-cell lymphoma as such a terrible lymphoma. It is a disease that we approach with curative intent for really nearly all of our patients. That is our goal, and while unfortunately we don't achieve that all the time, I think we're getting better and better, and that's what excites me about T-cell lymphoma, that we've been able to understand the disease better, and there's such a plethora of new drugs that hopefully will be an improvement over the current treatments that we have. And I hope that there will be a time where cytotoxic chemotherapy is no longer the initial frontline therapy, but it will be also important to make that treatment accessible to everybody. And that is not even true in the United States, but for sure it is not true worldwide, where a lot of patients do not have access to appropriate therapy and all the new and exciting things that we at times can offer. So I think one of the messages is for the physicians in the United States that we can treat peripheral T-cell lymphoma, but we still don't do as well as we hope to, and we can do better for our patients. And the one way to do it is clinical trials. So always think about clinical trials, especially for these rare diseases, where we need a lot of information, and we always appreciate the volunteers, the patients. I think they're so brave in volunteering to advance the science, not only for them. It's so generous also how they think about, while it might not help me, but it might help other patients. And I think that's what we need. I know all my colleagues are all very so passionate about this disease and about advancing research. And through advancing research, advancing the outcomes for our patients. So I think that's the important part to have, especially if there is access clinical trials in mind, because there's so many new exciting drugs that hopefully at some stage will offer cure to even more patients than currently. But there's a lot of open questions, and I think we'll be working on. I don't think there's ever going to be a perfect answer. We can always do better, and I'm excited about to be part of that and be part of this group of, as I said, very passionate colleagues and very brave and courageous and gracious patients.
Thank you so much, Stefan and Estelle. And I'm sure with, talented physicians like you and Estelle, I think the future is going to be very bright. This podcast is sponsored by Pfizer, Secure Bio, and Corvus Pharmaceuticals. For more information about PTCL, please visit PETALconsortium.org. We appreciate you listening in. Have a great day, and we will see you next time on PETAL Podcast.